Welcome to Medscape Oncology Insights. I'm Dr. John Marshall. I'm the director of the Otto J. Ruesch Center for the Cure of GI Cancers at Lombardi Comprehensive Cancer Center at Georgetown University. And joining me is not only a very good friend, but an amazing person in the world of GI cancer on so many levels, not just the data, but the human side of well. This is Dr. Mark Lewis. He's the director of GI Oncology at Intermountain Healthcare in Utah. Mark, how you doing?
I'm doing great, John. It's so exciting to be here with you. I think this is our first in-person ASCO meeting in several years, and the excitement is palpable.
You know, I think the best part about being in person is you can sneak around the booths and steal stuff and not have to talk to the people at the booths, but we'll talk about that later. We've got actually quite a bit to talk about, and we'll just focus on colorectal cancer. And when I first saw the list of abstracts, I thought, oh my gosh, we have the #1 abstract. Colon has the #1 abstract in the plenary session. And then I'm thinking, there's some new drug I don't know about. Something has happened. Then I looked at the title and I thought, this study's been done before, like 10 years ago. And yet, why would it be the #1? So maybe walk us through the study and what it showed.
Yeah. So what did Yogi Berra say? Deja vu all over again, right? So I think it's just such a fascinating study because it was essentially asking the question, John, so this is paradigm that you're referring to. In the first line setting in metastatic colon cancer, what is the best biologic agent? And it was a Japanese trial. We can get into specifics in a second. But I think the reason it evokes so many memories for us is CLGB 80405, FIRE3, PEAK, all in their slightly different ways attempted to answer the same question. And it's striking that you would point out the lack of novelty of the agents, because to me, I think the takeaway from today was sidedness matters oh so very much. And I think now we're getting a hint about sequencing as well. But in this trial, the Japanese investigators took roughly 400 patients in each group, and they received either FOLFOX with panitumumab or FOLFOX and bevacizumab. And the results were fascinating. Again,
RAS wild type?
Yes, all RAS wild type, exactly right. And an interesting focus and an understandable one on left-sided tumors. And there was a little bit of a change in schema over time where you could tell initially the focus was going to be on all comers. And then there was a focus on the left-sided tumors, which understandably enriched some of the response and survival data, and then an expansion to the entire group. So the right-sided tumors were represented, but understandably were a minority.
Let me go back because I think with those original studies that were done, there were some parts of the world that believed the left and right. US believed it, Europe did not. There were some parts of the world that didn't really embrace EGFR. We didn't, the Europeans did. And so in some ways, we both were wrong and we both were right in the end. Does that fit?
I think that's extremely fair. And for all the sophistication of our science, John, I'm constantly humbled to remember that one of the greatest advances in GI oncology in the last decade was this realization that maybe the right and the left colon are different. Exactly. Embryologically, they're different. The junction between the midgut and the hindgut is somewhere in the transverse colon.
It's not that at all. It's all microbiome.
Oh, boy.
Gonna be microbiome.
How much time do we have? Yeah. No, but I think it's really important to think about this in the stage 4 setting. And what I'm getting at is a breast cancer oncologist would never treat one of their patients without knowing at the very least ER, PR, and HER2. And now as GI oncologists, I think in the metastatic setting, we have to think about sidedness. And it's so interesting, and thank you for finding this was the RAS wild type population. Dr. Yoshino in his conclusions was sort of advancing that for left-sided RAS wild type, the FOLFOX panitumumab is now the first line.
Gotta be.
And then Dr. Cremolino in her sort of refinement of that said, well, listen, let's not forget about microsatellite stability, and let's not forget about BRAF. And I thought that was really important and sort of gets down to the fact that we are looking now at taking a very common cancer and we're not lumping, we're splitting.
Well, so I sort of went exactly where you were going, and that is in breast cancer, they even have different rooms for ER, PR, HER2, triple negative, where we've all been in the same mosh pit and sorted it later. And I think, to me today, this paper says we've got some distinct rooms now. We have the RAS wild type sided, left-sided. We have all RAS mutations. They're their own space, and actually the largest group at present, maybe 50, 60%. We then have MSI, I'll call the others, MSI, HER2, and BRAF, each in their own, having their own pathways, if you will. So I think now we have to prospectively pick patients for trials based on what kind of molecular profile they have.
Precisely, because again, a breast cancer trial would never sort of be histology agnostic up front, or seldom. The design would include this sort of stratification, and I think we're going to have to do the same. Someone on Twitter was joking after today's paradigm presentation that from now on it's going to have to be left-sided colon cancer subspecialists and right-sided colon cancer subspecialists. I don't think we're there, but I think
we are there in Washington with left and right. It's clearly you're either one or the other. There is no transverse colon in Washington, D.C. for sure.
Yeah.
So this brings to me the fact that we have to do broad profiling in everybody in frontline because we need to know what pathway they're on. Let's go to adjuvant. Let's do a second one. In this case, neoadjuvant, which was an incredibly brave paper. I thought brave study to do, but exactly on point with a remarkable a result that makes it to the New York Times this morning. Andrea Sursek and her group in New York, in Manhattan. It's 11 patients they originally reported. I don't remember how many they reported here.
I think it was a dozen here, actually.
Now, one more. Can you talk us through why this 12 patients is such a big deal?
Yeah, and exactly. And to see this already escalate to the level of, mainstream press coverage in the New York Times, it's remarkable. And I think it speaks to why even such a small sample size is reverberating. So here we were looking at single agent anti-PD-1 therapy with dostarlimab in MSI-high locally advanced rectal cancer, so stage 2, stage 3. And the whole point, as you know, John, in rectal cancer has been how much can we do upfront that might avoid trimodality therapy. And what I'm getting at, and I'm wading into very controversial waters here, is watch and wait. And what was so fascinating about this study is by administering the checkpoint inhibitor upfront, they saw so many, like you say, 100% clinical complete responses. They actually did not advance to chemoradiation. They did not advance to surgery. And we should be honest, with still relatively short follow-up, all of these patients remain in that remission. It's absolutely remarkable. And especially to think about the MSI-high population. I gave a talk at ASCO, at this ASCO, about the special burden that patients with germline cancer syndromes carry, including myself, if I'm perfectly honest. And so to see patients with, say, Lynch syndrome potentially be spared the rigors of trimodality therapy it's incredible.
So many things that are exciting about this. The investigators point out that there was a higher proportion of Lynch patients in these rectal tumors compared to, say, up in colon, where you see more sporadic MSI high. So there's that. And in fact, we know that there are probably different proteins tracking with Lynch than sporadic. So there may be something there. In the metastatic disease, we're not seeing 100%, right? We're seeing more like 50%.
Yes.
And so with this enriched, localized disease cohort, they went 12 for 12. So what's the next study, right? So to me, you're not going to randomize. You're just going to keep going and keep following and set the standard. Isn't that what you would do?
That's exactly what happened. So actually I had many people kind of talk to me today and say, well, how do you do the randomized study now? I mean, essentially, have we destroyed equipoise? And also the fact that this has already reached the attention of the national news media. I mean, patients are so savvy, they're going to be aware of this. And someone said on Twitter, it's going to be difficult to sit down in clinic this week and not have a conversation with an MSI high locally advanced rectal cancer. It doesn't involve this immune therapy approach. And then we'll see what happens, but very, very watchful waiting. To me, the key is ongoing vigilance. Already, this area of rectal cancer observation was sort of fraught with tension. And I think the trade-off, sort of what you are exchanging for is you potentially here losing the surgery, but really committing to very, very rigorous follow-up.
Yeah, these patients are going to be able to sit down more comfortably in clinic with this new approach if they have Lynch syndrome or MSI high rectal cancers. One of the tools I've been using to follow and watchful waiting is ctDNA. And we've had one major publication out of that same Japanese group that just wowed us today.
Yes.
They wowed us in San Francisco back in January with some remarkable data in the adjuvant space. A different group with a different test actually came forward with their version of impact of MRD, minimal residual disease, positivity or negativity in the adjuvant setting. Kind of give us the high level on that.
Certainly. So, I trained as a hematologist oncologist, but for the last several years, I've done only GI oncology. And I have to admit some sour grapes when I saw my colleagues who were in the hematology space having all these, minimal residual disease assays at their disposal. And now I think we have increasingly evidence that MRD can work in solid tumor oncology, and specifically it can work in GI oncology. So here we were facing the very vexing clinical quandary of stage 2 colon cancer and adjuvant therapy decisions. And John, I've often framed this through the very sort of basic medical ethics problem of the trolley problem. So this is how I first sort of came to grips with adjuvant chemotherapy. When I was first taught about adjuvant chemo as a fellow, I thought, wait, hold on a second. You want me to give chemotherapy to someone that has no visible signs of cancer? How can I do that and remain consistent with, primum non nocere? And then it was explained to me about, micrometastases, and I said, okay, I can now do this and sleep at night. But, we've known, or maybe not known, from Quasar and Mosaic that to benefit a large number of stage 2 patients, or even I should say a small number, we have to treat a large number. And that, of course, is risked over-treatment. So again, thinking about pulling that lever and diverting away from a huge catastrophe, but you still know you're inflicting some harm. So what I'm getting at in the trial you're referencing was using ctDNA negativity as sort of a way not to pull the lever at all and potentially avoid the prescription of adjuvant chemotherapy. And it's a fascinating study. I'd be curious to get your take. But I think what we're coming towards is, yes, we still need clinicopathologic classification of these cancers. I think we know they are necessary. I don't think we know they're entirely, in fact, I doubt they're entirely sufficient for fully informed adjuvant therapy decisions. And so I think what this trial gets us one step closer to is using circulating tumor DNA, especially positivity, as a sign for who needs adjuvant, whereas negativity may be a signal that that patient does not require adjuvant chemo.
Yeah, it's my exact take. And we are doing this increasingly. There are some now prospective studies being done across the world using different assay methodologies and different decision-making based on this. So it's not a one-size-fits-all. The whole goal, as you laid out, is to make us more efficient and quit giving treatment to people who won't benefit because they don't have cancer. Treat the ones that we're going to fix and have a reasonable idea, not having to wait 5 years if we were right or not, to know early on that things are going okay. And then third, I think equally important, is identify those patients that our current treatments aren't fixing.
Yes.
And those are the ones that need to be on a clinical trial. Because let's face it, we cured all the other ones. Right. We just didn't know how we were doing it. And now we can really pull out that group. And so everything becomes more efficient. Because of the very high positive predictive value of a positive test. It may be that soon we'll be better at the negative, so that's cleaner and even, it's pretty good now, but it's not perfect. So that's where we know we're on soft underbelly, but we'll get there one day. So it's been an exciting meeting. We need to get back out there and learn what's next coming. So thank you very much for joining today. And it was great discussion as always. So Mark Lewis is, as I said and promised, just amazing and knows what he's talking about and puts it in the context that's useful for everyone. And thank you for joining us for this episode of Medscape Oncology Insights.